All right, you guys. So we're jumping into another complex disorder here. This is lung cancer. And this one's going to take us a little bit to get through, but it is definitely one that is prevalent, especially when it comes to those that have exposure to noxic or toxic chemicals, those that have exposed themselves to firsthand or even secondhand smoke, and just a lot of different complexities when it comes to lung cancer. And we're going to jump into those right now. So, when we look at cancer, this is simply looking at any abnormal new tissue growth. And sometimes we can call that abnormal growth a tumor, or another name for a tumor is a neoplasm. And that's just abnormal growth of new cells. So, sometimes we use tumor, sometimes we use neoplasm, sometimes we use cancer, and those are all pretty much interchangeable. Now, when we kind of break down the tumors or the neoplasms, we have to understand the difference between a benign tumor and a malignant tumor. And when we talk about benign tumors, these are the more safe, if you will, or the less damaging tumors. These do not endanger life at all. They are slow growing and they push tissue aside. So they are space occupying lesions. And when we look at benign tumors, these will not migrate, they will not travel, they will not move to other body systems. Benign tumors, they stay encapsulated. They are in their own little world. Now, the malignant tumors, these are rapid, these are chaotic, these have just a sense of rapid growth that has no rhyme or reason. And when we look at malignant tumors, these are embryonic, these are primitive, and they're poorly differentiated cells, meaning that they just kind of do what they want. And they can cause necrosis, they can cause ulcers, they can cause cavitations or holes, and we definitely don't want those things, right? And these are invasive to the surrounding tissues. So they go from their specific area into other organs and other systems. And these originate in the epithelium of the tracheobronchial tree. It's kind of the way that I think about tumors, whether they are benign or malignant, is I kind of think of them as Debo from Friday. Is they're going to take your chain and they're going to make you like it. They're going to occupy space. This is their block. This is my chain, homie. And this is what I think about when I think about tumors because they don't care. They don't care what's there. They don't care whose space this is typically supposed to be. They just take over and they run. The benign tumors, they'll grow slowly. But the malignant ones, they have absolutely no rhyme or reason as to what they are doing, and they will simply take over. Now, when we look at specifically bronchiogenic carcinoma, what we're looking at is a form of lung cancer where the tumor enlarges and the tissues and the bronchioles, the alveoli, the airways are all irritated, they are inflamed, and they swell. And the adjacent alveoli fill and they become consolidated or they collapse. So we get this carcinoma, this cancer that starts to occupy space. It moves these tissues and these anatomical structures aside, and from them having to move, it makes them swell. And when they swell, they secrete and excrete fluid. And that fluid will then fill into the alveoli, and that will create some consolidation in those airways, or it'll wash out the surfactant, and that will encourage them to collapse. So these tumors actually protrude into the tracheobronchial tree that produce mucus. This will create an obstruction and the blood vessels themselves start to erode. And then the blood that enters the tracheobronchial tree will start to enter the alveoli and the airways, and that will cause hemoptysis. So we will see these patients start to cough up frank blood. Tumors may invade the pleural space, impacting the mediastinum. They can invade the chest wall, the ribs, the diaphragm. There's no, they don't care. Again, they are Debo. They do not care who's in their neighborhood, whose chain that is, whose mama gave you that chain, they don't care. They just take over. And that is what is so damaging about these tumors. If we start to get these tumors that impact the pleural space, it can lead to pleural effusions. So not only can we see hemoptysis, but we can also start to see pleural effusions. And you have these space occupying lesions that are the tumors, and now you have a space occupying lesion that's the pleural effusion. So that creates alveolar collapse from these two other disorders or conditions that are taking up space. You can see atelectasis very prominently with cancers. So when we talk about the anatomical alterations, what we're talking about is inflammation, we're talking about swelling, we're talking about destruction, we're talking about increased mucus production because they're doing everything that they possibly can to get rid of any of those foreign bodies that are taking over that space. That increase in mucus production can lead to mucus plugs. Those plugs can lead to obstructions. Obstructions lead to atelectasis, which further leads to more consolidation. And you can end up with cavity formations, meaning there's holes or voids in the lung. And all of that consolidation can spill over from the airways into the pleural space, causing pleural effusions. When we look at cancer, lung cancer is the second most cause of cancer. When we look at men, prostate cancer is the number one cause of cancer. When we look at women, breast cancer is the number one cause of cancer in women. So it takes over more than 155,000 deaths per year. Heavy smokers are 64 more times likely to develop lung cancer. 80% of lung cancer deaths are associated from smoking. And the higher your pack years are, the more at risk you are. 7,000 deaths are associated to secondhand smoking as well. And it really doesn't matter. Are you smoking vapes? Are you smoking cigars? Are you smoking pipes? Cigarettes? It doesn't matter. You can get lip, mouth, or throat cancer even from the forms of smoke, cigars, and pipes that you don't fully inhale, that you just keep the smoke in your mouth, and that can lead to cancer as well with the lips, mouth, or even throat. There's a difference between Marlboro Reds and Marlboro Lights, but the question is, do you think that that mitigates the risk for cancer? It really doesn't. What about menthols? Do you think menthols will change or impact your risk of cancer? It really doesn't. What's crazy about the menthols is the menthols will have a less, they're not as hot. The mint is cooler to the airways. And what's crazy is the airways will actually allow that smoke and those toxins and those fumes to get into the airways even deeper than the lights or even the reds. So, some good questions here. See if you can find some information on them. Yes, we know that exposure is a massive risk when it comes to acquiring or getting lung cancer. And there are a number of different exposures that we could get when it comes to lung cancer. So we have 2, 4, 6, 7 different exposures that are listed here. And radon exposure is a radioactive gas that breaks down uranium in the soil and the rocks. If you are working in a space or a place where there is radon, if you're outdoors, that's okay. There's enough ambient air to kind of eliminate the exposure. But if you're working in a place or you have a patient that's working in a place to where radon is used indoors, that's not good. Asbestos is a exposure risk for mesothelioma, inhaled chemicals, whether that's arsenic, beryllium, cadmium, selenium, vinyl chloride, nickel, chromium, coal, mustard gas, chloromethyl. These are all different forms of inhaled chemicals that would be a risk for having an increased exposure to lung cancer. Being around diesel exhaust all the time. So our heavy machine workers, our diesel mechanics, these patients are more at risk. Highly trafficked road areas, I have a good friend of mine in Tulsa who is responsible for looking at the air pollution of different cities. And Houston is a hotspot when it comes to air pollutions and what it does to the pulmonary risks. I had no clue that my buddy, who's a chemical engineer, and I, as a respiratory therapist, made there's so many overlaps between what we're looking at and what we're doing. Arsenic, you can have arsenic in the drinking water. You can have radiation therapy from other cancers like breast cancer. And then there's always the personal or family history of cancer, and that increases your risks as well. When we look at the different types of cancer, you have two different types. You have a small cell lung carcinoma and you have a non small cell carcinoma. And the book abbreviates this as SCLC and NSCLC. So when we look at small cell lung carcinoma, this spreads aggressively and responds to chemoradiation almost exclusively to smokers. 15 to 20% of all lung cancer in the US is associated with these small cell lung carcinomas. When it comes to the non small cell lung carcinoma, these are more common. About 75 to 85 of all lung cancers in the US are associated with these non small cell carcinomas. And these can have a surgical intervention. And we're going to talk about the specifics of all of these as we go through this talk. So, looking at the non small cell lung carcinoma, we're going to just jump right in. So, when we look at this, one of the ones that we look at is called squamous cell carcinoma. And this has seen a sharp decline over the past 2 decades. These are commonly located near the central bronchus and the hilus, and it projects into the large bronchi. When we take care of these patients, a lot of times when we are doing a bronchoscopy or we're investigating why patients are breathing and having as much dyspnea as they are, we'll do a bronchoscopy and we will see the tumors during the bronchoscopy. Typically, these originate as basal cells in the bronchial epithelium and they grow through the epithelium before they start to invade the surrounding tissues. These typically they have a late metastasis tendency, meaning that they're going to be benign for a really long time before they start to metastasize or become metastatic. And these do create cavitations or cavities and necrosis. These are typically common findings when it comes to the squamous cell carcinoma. Chemo does not work very well with these patients, and they will typically have pneumonias, reoccurring pneumonias, and atelectasis. So when we look at squamous cell carcinoma, about 25 to 30% of bronchiogenic carcinomas are squamous cell carcinoma. These are commonly located near the central bronchus or the hilum or the hilus. And like we said, during a bronchoscopy is when we are going to see these tumors firsthand, and they are slow growing. Remember, they start as basal cells and they continue to grow through the epithelium before they start to take on a new life form in the surrounding tissues. You will end up and see a enlargement of the hilar lymph nodes. You'll get that cavitation and the necrosis that are the common findings. When that happens, there's going to be a increase in production with sputum. That excessive sputum can lead to obstructions and the tumor itself growing in the airways can cause obstructions. We're going to have non-productive dry coughs and some hemoptysis with that pneumonia and atelectasis over time. So the next form of non-small cell lung carcinoma is the adenocarcinoma. About 40% of bronchiogenic carcinomas stem from adenocarcinoma. These stem from the mucus glands of the tracheobronchial tree. So when these guys start to proliferate, when they start to multiply, you're going to get a massive increase in mucus production. That increase in mucus production could lead to mucus plugging. That plugging can lead to obstructions. But not only do you have the mucus plugging, but you also get these carcinomas that are growing inside the tracheobronchial tree that can lead to obstructions as well. This particular cancer has the weakest association with smoking. So people who have never smoked, this is the most common. This one is the most common form of lung cancer that they will have. We see that this lung cancer will actually metastasize very early, and they have a slow growth rate, but they are unpredictable in that growth rate. Since there's so much mucus being produced, a lot of times that overproduction of mucus has to have a place to overflow, and the overflow is going to be in the pleural effusion. So you have pleural effusions that are a common theme and a common sign when it comes to the adenocarcinomas. If discovered early, we can have surgical interventions, and these patients end up doing really well. But those that aren't caught early, like I said, there is an unpredictable growth pattern and there's early metastasis. But it's something that can be detected, but if we don't detect it early, we can get metastasized cancer to other areas of the body. When we look at large cell carcinoma, these arise peripherally and they are found centrally. So these we are going to identify more centrally located than out in the parenchyma like the adenocarcinoma. So the large cell carcinoma is referred to as undifferentiated large cell anaplastic cancer. So just a big long form name for large cell carcinoma is undifferentiated large cell anaplastic cancer. These arise peripherally and they can be found centrally. They start to distort the trachea. You'll see shifts in the trachea and the large airways, and these guys have rapid growth rates. They are moving quickly, and you get metastasis very early, and it spreads very quickly. Complications that we see with these large cell carcinomas, you're going to have chest wall pain, you're going to have pleural effusions, hemoptysis, pneumonias, and these will also create cavitations as well. So these arise peripherally, but then they are seen or they are found centrally. When they're found, they're typically found with moving. Remember, they're space occupying. They're moving the trachea and the large airways away from the affected side. So one of the tools that we have to classify and also stage the tumors is we have what's called a TNM scale or a TNM staging. And the T stands for size and location of the primary tumor. N looks at regional lymph node involvement, and M, as in monkey, is looking at the extent of known metastasis. So is this impacting the brain, bones, adrenal glands, liver, kidneys, or other areas of the lungs? So when we look at this, you can break this down between T1, 2, 3, and 4, and you can look at less than 3 millimeters, any size, and invading into the intrathoracic structures from 1 to 4. When we look at our nodes or the lymph nodes involved, we're looking at N0 to N3. So no lymph nodes would be 0, and the contralateral, meaning the opposite side, its spread to the opposite side would be the N3. And then metastasis is going to say, look at an M0 and an M1, MA, and MB. So we have 3 different scales that we use when we're talking about classifying these lung cancers. Other things that we may actually be more familiar with is staging. You have stages 0 and 1, stages 2 and 3, and then stage 4. So when we look at stage 0 and stage 1, it's stage 0 and stage 1, the cancer is confined to the lung, meaning it has not spread and it has not metastasized to other areas. When we look at stage 2 and 3, the cancer is confined to the chest with larger tumors. And then in stage 4, the cancer is spread to other parts of the body. And I actually just got notified this past Thanksgiving break that my grandfather, he was actually diagnosed with stage 4 lung cancer, and it had already metastasized to his liver, and it had metastasized to his kidneys. Staging is a way that we can identify how bad the cancer is. So another way to look at this is you have just one little hot spot here. The tumor is in and confined to an area. So stage 0, stage 1, it's confined. Stage 2 is you start to get lymph node involvement. Stage 3 is the tumor is invading surrounding tissues. And then stage 4, the tumor is in other organs. So this is another way that we can identify and stage lung cancer to help us recognize stage 0 through stage 4 lung cancer. This should be a 4, not a 6. I don't know why that shows 6, but anyways. So when we look at the survival rate of lung cancer, it depends on the stage and is it confined or is it outside of the lung? Has it spread or has it not? So when we look at survival rates, we have 1A, which means that the tumor is confined to the lungs and it's less than 3 centimeters. So confined to the lungs and less than 3 centimeters means that you're going to have your 5-year survival rate is about 49%. About 50% survival rate of 5 years when you have lung cancer that is less than 3 centimeters and confined to the lung. When we look at stage 4, when it's metastasized to other parts of the body, the survival rate is about 1% for making it 5 years. So we have 1A, 1B, 2A, 2B, 3A, 3B, and stage 4. So when we look at 1A, this is a tumor that's less than 3 centimeters and it's confined to the lungs. When we look at 1B, this is a tumor that is greater than 3 centimeters but less than 4 centimeters and confined to the lung. When we look at 2A, this is greater than 4 centimeters but less than 5 centimeters and has not spread. When we look at 2B, and this is what's crazy, this isn't a typo, but when you have a tumor that is greater than 4 centimeters and less than 5, and it has spread to other areas, that survival rate, that 5-year survival rate, is 31%. When we look at stage 3s, we have 14 and 5% respectively. This is looking at only the lymph nodes, and this is looking at spread throughout the chest. And then stage 4 is looking at other parts of the body. So just an idea of what the 5-year survival rate is based on the size of the tumor and if it's spread and where it's spread. When we talk about treatment, there is what's called a pneumonectomy, which is the removal of the entire lung. We can have a lobectomy, which is the removal of an entire lobe. You can get a subectomy or a wedge resection, which is removing the entire segment or a part of the segment. These are all different surgeries that can be performed to help remove the tumor or to remove the cancers. Then there's what's called a video-assisted thoracic surgery, and this is used to treat early stages of lung cancer located in the pleura or the peripheral parts with just a smaller incision. Almost like orthoscopic, kind of, but you still get a teeny tiny little incision. You can have radiofrequency ablations. This is a thin needle that's inserted into the tumor and you send electrical current to heat the tumor and cells and actually destroy it. We can have radiation therapy, we can have chemotherapy, and we can have targeted drug therapy, which are designed to shrink the blood vessels or the tumors themselves by shrinking the blood supply to those. When we look at small cell carcinoma, again, this is more associated with smoking, and another name that we can use when it comes to small cell carcinoma is oat cell carcinoma, OAT, oat cell carcinoma. So these typically hit the larger airways, and secondarily, they're going to hit the bronchi. We will see with these small cell carcinomas that these are only about 10 to 15 of all lung cancers. They typically start near the hilar region and invade the larger airways, and they're about 6 to 8 micrometers in size. And we see that there's a rapid growth and they become large very quickly and they metastasize very early. There is typically a poor prognosis when it comes to taking care of these patients. Usually it's about 1 to 3 months if these small cell carcinomas are not treated. But it can be successfully treated with chemo and radiation. There is a typical relapse period that could happen within the next 2 years if treated with chemo and radiation. When we look at staging, these stagings are a little bit different, but when we look at it, we can look at, is it limited or is it extensive? So if it's limited, all we're doing is we're saying that the tumors themselves are confined to the chest. When we have a small cell lung carcinoma, and we call it an extensive staging, what we're saying is this is moved beyond the chest. So it's something that is outside of the chest or has migrated or metastasized. So the staging process when it comes to the small cell carcinomas is it's a lot easier. We have stage 1, stage 2, stage 3, stage 4. We don't have the A's and the B's. We don't have a lot of additional information when it comes to this staging. So when we look at the staging, we're looking at less than 3 centimeters, between 3 and 4 centimeters, between 4 and 5 centimeters, and greater than 5 centimeters. And that's we're talking about the tumors themselves. So if we have a less than 3 centimeter tumor, a 31% survival rate at 5 years. Then you have a 31% 5-year survival rate. If it's between 3 and 4 centimeters, it's less than 19. If it's between 4 and 5 centimeters, less than 8. And if it's greater than 5 centimeters, then you have a 2% 5-year survival rate. So treatments for these small cell carcinomas, you got chemotherapy. We have different combinations of chemotherapy. I am not an oncologist, and I'm not going to break these down into how these chemotherapies work. I just know the combinations that we could use and we would try for our patients with small cell carcinoma. With radiation, we have what's called the EBRT, and this is the most common form of radiation. We'll talk about these different forms of radiation here in a bit. The other form of radiation is the 3D CRT and the IMRT. So these are 3 different forms of radiation that we can use, but the EBRT is the most common. When we look at surgeries for these small cell carcinomas, surgery does not work very well when it comes to small cell carcinoma. And we've got to make sure that we are following up with these patients who have had chemo and radiation because there is that relapse period. So when we look at other lung cell carcinomas here, we've got lung carcinoid tumors, and these are made up of different special cells. And these different cells are what are called neuroendocrine cells, and there's different subcategories within this. So this is kind of the other when it talks about lung cancer. When we look at lung carcinoid tumors, they are classified by location. They can be central, they can be peripheral, they can be additional, and then these can spread into the lung. So additional would be some lymph node involvement and spread throughout the lungs. So when we go through our different screening and diagnostic tools for lung cancer, this is kind of what we're looking at. When your patient arrives, they're not typically diagnosed until after the patient presents with symptoms that suggest lung cancer. So your patient that presents with hemoptysis, or your patient that presents with recurring pneumonias or atelectasis, they're not going to automatically get diagnosed with cancer right away. We're going to kind of go through all of the workup to make sure that they don't have different types of pneumonia or tuberculosis or other disorders before we fully give them a diagnosis of lung cancer. You will see these patients end up with progressively worsening coughs, non productive to productive sputum. That sputum could be bloody or it could be rust colored sputum. These patients may have chest pain that are associated with deep breathing, coughing, or even laughing. The lung cancer can spread to the backbones or even the hips, and that would cause some pain. You can have neurologic problems, whether that's headaches, arm and leg weaknesses, or numbness. You can have dizziness, balance problems, seizures. You can get lymph node involvement. You can have the mediastinum, the neck, or the axilla that are all involved. But when we see this, we see a progressive worsening cough, chest pain, a hoarse voice, poor appetite, weight loss, shortness of breath, fatigue. They could end up with frequent bronchial infections or pneumonia, a sudden onset of wheezing, bone pain, neurologic problems, jaundice, enlarged lymph nodes. So, a host of different signs and symptoms that we would have. And some of these have overlap with pneumonia, some of them have overlap with tuberculosis, and we would definitely need to see what's going on before the patient can be diagnosed with lung cancer. So these are very specific syndromes that are associated with lung cancer that we could see these syndromes that would take us down the path of identifying that the patient does have lung cancer. And we have the Horner syndrome, the superior vena cava syndrome, and the paraneoplastic syndrome. And they each have their own unique signs and symptoms. So, like with the Horner symptom, you're going to have small pupils, you're going to have weakness or drooping of one eyelid, and this would help us recognize that there's nerve damage that's impacting or near the apex of the lungs. So, this could be a sign that the patient has lung cancer. Same thing here with the superior vena cava. You have upper portion of the right lung that's compressed by the superior vena cava, or that's suppressing the vena cava. So you have decreased venous return. Your patient's going to have like face, neck, or upper arm, chest swelling because none of that blood is circulating the way it's supposed to. So very specific kind of signs and symptoms that we see with this superior vena cava syndrome. In the paraneoplastic syndromes, you could have a variety of tumors that could lead to growth in the bones. You could have metastatic cancer into other areas like creating blood clots and just a variety of tumors when it comes to the paraneoplastic syndromes. So, what do we do when we identify these signs, symptoms, and syndromes? What are we supposed to do? Well, whenever you're doing your full medical history and you're getting your physical exam, you want to assess and check for risk factors. So, you want to ask questions, open ended questions, especially if they've had any potential exposures to any of those that increase the risk for lung cancer. And not only while we're doing our assessment and doing our getting our medical history, we want to start thinking about additional diagnostics when it comes to lung cancer. So, those diagnostics that we're going to think about are to identify suspicious areas in the lungs. So, a lot of times when we get a patient that has shortness of breath, they may end up with a chest x ray. And we may see something on the chest x ray that leads us down the path of, oh, we need to look at that a little bit further. If we do identify that the patient does have some sort of neoplasm, then we need to identify if and where that cancer has spread. We need to start getting these patients on some sort of therapy, some sort of regimen, so that we can evaluate the effectiveness of that treatment and we can assess the signs that cancer has returned post intervention or that patient's had a relapse. So, once they go into remission, or if they go into remission, it doesn't mean that they are completely cancer free. I take that back. They are cancer free, but it doesn't mean that the cancer won't come back and it won't spread. So some of the things that we're going to look at imaging. We're going to start to identify what some of the um, cancers are, and we can do some analysis when it comes to the different types of cancer that are out there. So we've got 5 different types of imaging that we can use. Like I said, this typically going to start with a chest X-ray, and you're going to see something, and it's like, that's not supposed to be there. Then we're going to get a CT. That CT could lead to a PET scan or an MRI and even a bone scan. So these 3 down here are going to be if and when the CT is confirming a diagnosis of lung cancer. When we look at identification, we can look at sputum cytology, so we can have that patient cough up a sputum, and we'll take that sputum down to the lab and we'll do some testing on it. Bronchoscopy, this is a needle biopsy or a brushing biopsy. In the bronchoscope, there is what's called a working channel. That working channel is an open port to the distal end of that bronchoscope. So you can see through the camera your little brushes or your little tools so that you can grab and pinch the foreign cells and then pull that back through the bronchoscope and get a sample. There's what's called an EBUS or an endobronchial ultrasound. This is an endoscopic esophageal ultrasound, basically where we send it looks like a bronchoscope, but a bronchoscope down the airways, and it sends ultrasound waves so that we can see what's going on. Very similar to what we have with our ultrasound wand, with what we can use for vascular access or point of care ultrasound, looking at the lung scanning using the Blue protocol. But the EBUS is like a bronchoscope that sends ultrasound signals. We can do a thoracentesis. We can do that video assisted thoracic surgery. Remember, that's that teeny tiny microscopic incision so that we can get that peripheral abnormal cell growth. Then there's analysis. You've got the immunohistochemistry that we can do. We can do a molecular test, and we can look at the CBC. So a number of different tests when it comes to diagnosing cancer. So remember, we have this space-occupying tumor, this space-occupying lesion that is deboing this neighborhood. It's deboing this area. And you're going to end up with atelectasis. You're going to end up with increased bronchial secretions. So what do you think that does to oxygenation? Breathe more, beat more, hypoxemia, right? What's your lung compliance going to look like if you have these tumors and cavitations in the airway? Yeah, your compliance is going to go down, or they're going to have potential pain, anxiety. They're going to have a tracheal shift. There could be large airway shift. They can have cyanosis. They're going to be hypertensive, tachycardic. You're going to have dry, non-productive coughs to a productive cough that has hemoptysis. You could have crackles. You could have wheezes. Those crackles could be fine if it's fluid. It could be coarse if it's consolidation. When you look at ABGs, if you have a localized or a lobar lung cancer, then that would look like an impending ventilatory failure. If you have a widespread look at the tumors have spread out, then you could end up with acute ventilatory failure. And then this will impact our hemodynamics as well. We already started talking about the ABG, if it's localized versus widespread. Again, acute alveolar hyperventilation versus acute ventilatory failure. Your oxygen indices, how is this going to impact your shunt? How is it going to impact your delivery of oxygen? How is it going to impact your oxygen consumption? The difference between your arterial and venous oxygen, the exchange ratio, and what's going to be left over at the end. When you look at these patients, they're going to end up with hypoxemia and acidemia. They're going to be hypercarbic, so that's going to increase your PVR. All of that's going to increase all of the pressures on the right. When we look at other downsides to lung cancer, is it is a space occupying lesion. It is going to take over, and it doesn't matter if the heart is supposed to be in this area. It will take over the mediastinum. If it takes over the mediastinum, that will impact all of the hemodynamics, not just what's on the right side. And we can end up with SVC, or superior vena cava compression, meaning we're not getting blood back into the right atrium, and all that blood's going to back up into the superior vena cava, into the subclavian vein, to the internal jugular vein, and lead to a swelling. When we look at the pulmonary function testing, these these poor patients are going to have decreased flows and decreased capacities. So they're going to have obstructive disorders and they're going to have restrictive disorders. So lots of chaos when it comes to these neoplasms. When we look at the chest x-ray, you're going to see small or coin lesions. Sometimes these can be large irregular masses, but we're going to see alveolar consolidation, atelectasis, even pleural effusions. So here you can see this massive circular or coin or oval shaped lesion that's in the chest x-ray. This right here would give me more reason to want to investigate further. Like, what is that? We need a better picture and we need to get some identification as to what that guy is so that we can get this patient on the right treatment plan. Sometimes you have lung cancers that hide behind the cardiac silhouette, and you can see here that we have the lungs. They have a haziness to them. There's a consolidation to them, and we can see there's a small coin-like or a circular lesion here, and then there's one that's hiding here behind the heart. Well, this one here that doesn't have anything blocking it, I can see that pretty well. But this one that's behind the heart, I would need to investigate further. So whenever I investigate further, the next step up would be to do a CAT scan. And whenever I do a CAT scan, this circular lesion that's behind the heart is what this is here in the CAT scan. So we're able to see with more clarity what that means, because if I think about it, the CAT scan is almost like a ruler. And the CAT scan, what it does is it spins super fast around that patient. And it will cut the patient into centimeters or even millimeters. When it does that, we can take out a slice of that image, almost like a loaf of bread. We've got a loaf of bread and we can pull out an individual slice. That's what it's like looking at a CAT scan. So when we look at CAT scans, it's taking an individual slice out of this entire loaf of bread. So here I have this foreign opacity behind the heart that I needed more information on. I got the CAT scan and I can see this lesion here in the left lower lobe. If we're still a little unsure about what's going on when these patients presents, we can do what's called a PET scan, or a positron emission tomography. It sounds kind of like a transformer, this positron emission tomography. Just nerding out a little bit, but don't mind me. Anyways, you can use this to confirm those suspicious spots. And this is a form of nuclear medicine where these patients are injected with radioactive dye, and they're sent through this scan to identify if they have any quote unquote hotspots. This is a very, very good way for us to get very specific answers with high quality imaging to know exactly what those things are. So a PET scan is like a, let's highlight this for lung cancer diagnostics. The last thing that we could have here is direct visualization. So whenever I'm doing a bronchoscopy, if I see a tumor during a bronch, then then that thing is a tumor. So we can have direct visualization as another diagnostic when we are performing a bronchoscopy. Not only is it used for therapeutic and diagnostic, we need to be aware and situationally and environmentally aware of what we're seeing so that we do not miss a potential tumor. So when we get into the treatments of this, we already started kind of talking about it with the surgical interventions, some of the chemo, some of the radiations, and I kind of just highlighted some of those radiations, and we're going to jump into those a little bit more. So these radiations, these are the EBRT, the 3D CRT, the IMRT, SBRT, the SRS, and what's called brachial therapy. These are all different forms of radiation. When we look at the EBRT, this is our most common. This is our most common use of radiation, and these patients are getting radiation 5 days a week for 5 to 7 weeks. So when we look at these 3D CRTs, these are designed to do mapping of the tumors. And radiation beams come from all different directions so that we can get a 3D image of where that tumor is exactly. Then there's what's called the intensity modulated radiation therapy, or the IMRT. This is more advanced than even the 3D CRT. So with this one, the intensity can actually be adjusted. Then we have the SBRT. This is very focused, high dose beams and fewer treatments. So this is like I can precisely see that tumor, and I'm going to use these radiation beams to shoot them to try to destroy those. Typically, because the dosing is so high, they don't need as many treatments. But we can use this for small tumors, and there's very, very, very few risks with complications when it comes to the SBRT. When we look at the SRS, this is a conjunctive therapy with the SBRT that's done only one session, done as only one session. When we look at the brachial therapy, this is internal radiation, and we're actually having the patients have pellets placed directly into the tumor via a bronchoscope. So lots of different potentials and opportunities when it comes to radiation. I would definitely know and be able to differentiate the 6 different types of radiation here. So when we look at chemotherapy, there are a couple of different ways that we can do chemotherapy, and we can target our chemotherapy. We can do it as a before surgery, adjunctive therapy, conjunctive therapy, and a primary therapy. So these two are very similar, but they have 2 different targets. Okay, both of these happen before surgery. Before surgery and adjunctive are both before surgery. The difference is before surgery, what we're trying to do is we're trying to shrink the tumors. When we look at adjunctive therapy, we're actually trying to kill the foreign cells before surgery. So before surgery and adjunctive, both of them take place before surgery, but this one is designed to kill and this one's designed to shrink. When we look at conjunctive therapy, with conjunctive therapy, what we're talking about is using chemotherapy when radiation isn't enough. So we're getting radiation therapy plus chemotherapy equals conjunctive therapy. And then we can look at primary therapy. When we look at primary therapy, this can also be along with radiation, but this is what's going to take place when the patients are too weak for surgery. So the primary therapy is going to be way more for those that are too weak for surgery and simply getting chemo and radiation as primary therapy. So when we look here, these are all the different types of chemotherapy. I'm not going to create a list and make you memorize it. Just know that there are a number of different therapies or chemotherapies that are available when it comes to that intervention. But we know that there's some complications that are associated with chemotherapy. The one that we're probably most familiar with is hair loss. Back in 2021, I actually shaved my head. I've gone through a couple of different hairstyles. I've shaved my head so that my dad, who was going through chemotherapy at the time, he didn't feel left out. So hair loss is part of chemotherapy. Got a really good picture of him without hair. It was just hilarious. Not only that, but you end up with mouth sores. And sometimes you end up losing your teeth because the mouth sores are so bad. So a lot of times these patients will end up with a specific like toothpaste and a specific mouth wash that they use to prevent these mouth sores. They don't want to eat. There's a loss of appetite. There's normal nausea and vomiting, diarrhea, or constipation. So they can be plugged up or they can be loose as a goose. You got an increased risk of infection because our white blood cells are decreased. These patients are going to be easily bruised or easily bleeding because it'll impact their platelets and their clotting factor. And then they're going to end up with fatigue because the red blood cells are impacted as well. So some of these we may be familiar with the hair loss, loss of appetite, not loss of appetite, loss of appetite, and nausea and vomiting. I think these three are pretty common and well-known side effects to chemotherapy, but we need to be well abreast of all of the different side effects of chemo. Then we have what's called drug-targeted therapies, and these are different therapies that we use for lung cancer. So when we look at this, we have one, two, three, four different types of targeted drug therapies, and what these do is they are designed to obliterate or eliminate the blood supply to the tumors. That's all essentially what they're designed to. They're designed to shrink and starve out those tumors. It's almost like we figured out a way to do some like warfare almost against these tumors because they have a blood supply that feeds them. When they get that blood supply, they're able to proliferate and multiply. But if we can choke out their blood supply using these different targeted drug therapies, then we can shrink those tumors and we decrease the likelihood that they will grow and spread. Lastly, here, these are things that we are very well familiar with. These patients are going to need some oxygen. They're going to have extensive secretions. They're going to have atelectasis. We're going to need to aerosolize some medications, whether that's SABAs, LABAs, anti-inflammatory medications, even antibiotics we're going to see. These patients are going to end up on different um, modes of mechanical ventilation, whether that's invasive or non-invasive. We're even seeing that even some high flow nasal cannula can impact the ability for type 2 ventilatory failure. What was type 2 again? And what's type 1 ventilatory failure? Go back and remember those things because those are specific. But ultimately, we can end up with patients that are in type 2 ventilatory failure that's irreversible. And these patients are going to have a lifetime on mechanical ventilation, or they're ultimately going to succumb to this disease and, and pass. But we do everything that we possibly can to educate them, to treat them, to make sure that they can breathe just a little bit easier today. That is my job, is to help you breathe a little bit easier. And what your job is right now is to learn how to help these patients breathe a little bit easier. So my job isn't necessarily to help these patients breathe a little bit easier anymore. My job now is to help you learn how to navigate the ways and the paths and the waters to help these patients breathe a little bit easier. So we just need to know what we need to know when it comes to lung cancer, all the different types, whether it's small cell carcinoma or non-small cell carcinoma, which ones are associated with smoking, which ones aren't, which ones will respond to chemo, which ones won't, which ones respond to surgery, which ones won't, what are our diagnostics that we can do, how do we treat these patients so that they can ultimately breathe one day a little bit easier. That's what we've got when it comes to lung cancer. We will be back for sleep disorders in our next lecture.